Have you ever sat down in a doctor's office, on that crinkly paper gown, and opened your mouth, said, and wondered what exact mental checklist is running through their head?
Oh yeah, I think we all assume they're just like taking a casual look around.
Right, but in those 5 seconds that the little pen light is clicking on, they are actually actively mapping your cranial nerves, checking for cellular mutations, and mentally isolating the exact lymphatic pathways of your neck.
It's incredible.
It really is. So, welcome to today's deep dive. Today, we are cracking open a really fascinating set of internal clinical notes. These are specifically used to train ENT specialists, ear, nose, and throat doctors. And our mission today is to decode the hidden structure of medical observation. We're going to see how doctors act as detectives, moving from a patient story to a physical exam, and finally to a clinical conclusion.
Yeah, and it is a rigorously rehearsed choreography. I mean, most of us think of a medical diagnosis as this sudden eureka moment, right? Like the doctor just spots the disease and that's it.
Like on a TV show.
Exactly. Yeah. But looking at these clinical guidelines, you realize that high-level medicine is actually this process of systematic destruction.
Systematic destruction, I like that.
Yeah, a doctor arrives at the truth by meticulously proving what the disease is not. They're eliminating variables over and over until only one inescapable clinical conclusion remains.
I love that framing because looking at the first section of our sources here, the history of oral cavity symptoms, patients' verbal interview sounds less like an open-ended conversation and more like playing a really high-stakes game of Guess Who.
Yes, exactly like Guess Who.
Right. The no answers seem just as crucial as the yes answers to eliminate suspects. But the sheer volume of negatives they have to document here seems exhaustive. I mean, for a patient presenting with a non-healing oral ulcer or growth, the notes specifically require the doctor to write down that it was not caused by trauma,
right.
That it was not caused by ill-fitting dentures, not caused by a jagged tooth, and not from accidentally swallowing a corrosive chemical.
Yeah, and in clinical medicine, those are known as pertinent negatives, and they are the crucial, the first cuts in that process of elimination. If you think about the fundamental biological difference between an ulcer caused by a jagged tooth and one that just appears spontaneously.
Well, one is an external mechanical failure,
yeah.
Right, and the other is an internal system failure.
Precisely. If a jagged tooth is just, tearing up the side of your cheek, your mucosal cells are behaving perfectly normally. They're injured, they're inflamed, sure, but their DNA is doing exactly what it's supposed to do in response to trauma.
So you just fix the tooth.
Exactly. The doctor files down the tooth, the trauma stops, and the cells heal. But if you have a spontaneous, non-healing ulcer with zero mechanical cause, that implies the cells themselves have fundamentally changed.
Oh, wow.
Yeah, they're no longer following the biological blueprint. They stopped healing and started invading. So by ruling out that mechanical trauma right off the bat, the doctor immediately shifts the investigation from an injury profile to a potential malignancy profile.
So they clear the mechanical noise. But the notes don't stop there. The doctor then has to document what the growth is not causing. For instance, they have to confirm the ulcer is not causing restricted movement of the tongue, which at first glance seems weird. If the ulcer is just sitting on the surface of the cheek, how could it stop the tongue from moving?
Well, because the tongue is essentially this massive, complex bundle of skeletal muscles anchored really deep in the floor of the mouth and the throat.
Right.
So if a patient cannot move their tongue laterally, or if they can't stick it out, it tells the doctor that the invisible base of this growth, the part you cannot see from the surface, has infiltrated downward.
Like roots?
Exactly like roots. It is literally grown into the muscle fibers, physically tethering them, or it has wrapped around the hypoglossal nerve that supplies the electrical signal to those muscles. So a simple, no, my tongue moves fine, confirms the tumor hasn't reached that deep muscular layer yet.
That's wild. You are diagnosing depth without making a single incision, just by asking a question.
It's all about anatomy.
And there is a third category of negatives here, what the symptom is not associated with. The doctor asks if there is a history of hoarseness, stridor, hemoptysis, or hematemesis.
Let's translate those because they isolate the anatomical neighborhood. So hemoptysis is coughing up blood from the lungs or bronchial tubes.
Okay.
Hematemesis is vomiting blood from the stomach or esophagus. And stridor is this high-pitched wheezing sound that indicates a physical obstruction in the upper airway.
So the patient says no to all of those things. The doctor is mentally clearing the lungs, clearing the stomach, and clearing the windpipe.
Yes.
They are fencing the problem entirely within the oral cavity.
Exactly. And once they have built that fence with the negatives, they can finally look at the positive risk factors.
Right, which brings us to the specific hypothetical patient profile detailed in our sources. So we have a patient. The symptoms started 6 months ago, totally asymptomatic at first, but it's gradually increasing in size.
Yeah.
The discomfort now radiates towards the ear, and the patient has no history of chewing can, which is betel nut, right?
Right. Yes, betel nut.
No history of chewing can or chalia. But they do have a significant personal history, smoking 20 filtered cigarettes a day for 20 years.
A very classic risk factor.
Yeah, but I want to look at the difference between those last two factors. Why is chewing can categorized differently than smoking cigarettes in intake notes? I mean, aren't they both just introducing carcinogens into the mouth?
They are, but through entirely different mechanisms of destruction. When someone smokes 20 cigarettes a day for 2 decades, they're bathing the oral mucosa in chemical carcinogens like benzopyrene.
Okay.
And these chemicals directly bind to the DNA of the epithelial cells, causing these gradual mutations over a really massive surface area. Essentially a chemical burn in slow motion.
A slow motion chemical burn. Right?
Yeah. But chewing can, or betel nut, is a double threat. Not only does the areca nut contain highly carcinogenic alkaloids, but the physical act of chewing the coarse nut mechanically abrades the lining of the mouth.
Just scratching it.
Exactly. And on top of that, it's often mixed with slaked lime, which creates a highly alkaline environment that generates reactive oxygen species.
Wait, so can is simultaneously scratching the tissue open, dumping toxins straight into the wounds, and altering the chemical pH to prevent it from healing?
Yes, it's brutal. It creates a state of chronic aggressive inflammation that often leads to severe fibrosis before it even has a chance to turn into cancer.
Jeez.
So knowing whether the patient is a smoker or a pan chewer tells the doctor exactly what kind of cellular battlefield they're walking into.
That makes so much sense. And what about that detail of the pain radiating to the ear? Because if the ulcer is in the mouth, why would the ear hurt?
That is referred pain, and it all comes down to how our cranial nerves are wired. It's kind of like having a shared party line on an old telephone network.
Okay, I follow.
The trigeminal nerve, specifically the mandibular branch, supplies sensation to the lower jaw, the gums, the cheek, but it also has branches that innervate the ear.
Oh, I see where this is going.
Right, so if an aggressive tumor in the mouth begins to erode into that mandibular nerve, it sends a static-filled distress signal to the brain. The brain's sensory cortex receives this panic signal from that specific nerve pathway, but it can't perfectly pinpoint the origin.
So it just sets off all the alarms on that circuit.
Exactly. It triggers pain alarms in both the mouth and the ear.
A crossed wire in the brain switchboard. Okay, so before the physical exam even starts, the doctor knows they're looking for a spontaneous, tissue-altering disease in a heavily mutated environment capable of triggering deep nerve pathways.
That's the setup.
Which brings us to the exam itself. How does the doctor transition from this really high-level neurological deduction to the physical exam? Because looking at the examination of oral cavity protocol in the sources, the instructions are shockingly archaic.
They do seem very low-tech.
Right. The protocol starts with an exact script. Hi, I am Dr. Arka Chawi. With your permission, I'll examine your ears, nose, and throat. Very polite. But then, in an era of MRI machines and robotics, the manual explicitly instructs the doctor to test taste by literally placing actual sugar and salt on the patient's tongue.
Yep. Actual table salt.
Why on earth rely on this when we could just order a high-res scan?
Well, the foundations of clinical medicine rely on direct, unclouded human observation. And MRI is phenomenal at showing anatomy, but a physical exam is required to show real-time function.
Function versus anatomy.
Right. Think of the brain and the cranial nerves as a computer system. The MRI shows you the hardware, it can show you if a wire is physically severed or maybe compressed by a tumor. But putting salt on a patient's tongue and asking them to identify the taste, that tests the software.
You're checking if the electricity is actually making it from the tongue, through the facial nerve, up the brainstem, and into the conscious mind.
Exactly. No static image can tell you if a patient is experiencing the sensation of saltiness in that exact microsecond. Direct human observation tests the immediate functional reality of the nervous system.
Okay, I see the value in that, but
Great.
I'm looking at another low-tech measurement in the protocol that seems, well, incredibly intense. The doctor has to measure for trismus, which is restricted mouth opening.
Yes, lockjaw, essentially.
Right. They calculate the incisor edge distance, basically the gap between the top and bottom front teeth. And the grading scale is brutal. It says adequate is greater than 30 millimeters.
Correct.
Then grade first is 30 to 20 millimeters, grade 2 is 20 to 10, and grade third trismus is less than 10 millimeters, less than a centimeter.
Barely enough room to slip a straw in.
How does a mouth ulcer mechanically lock the jaw shut to the point where you can't even slide a grate between your teeth?
It goes back to our discussion about the tumor acting as an invasive root system. The muscles that open and close your jaw, particularly the medial pterygoid muscle, sit very close to the inner lining of your cheek and the back of your mouth. If a malignancy on the surface grows deep enough to infiltrate that muscle, the body's natural response to muscle trauma is to spasm.
So the muscle just seizes up and refuses to stretch.
It seizes, and eventually the tumor physically anchors the flexible muscle tissue to the rigid bone of the jaw. It's a total mechanical failure.
Wow.
Yeah, from a diagnostic standpoint, grade 3 trismus is a glaring red alarm. It means you are no longer dealing with a surface lesion. You are dealing with a deeply invasive tissue-binding mass.
And the manual recommends measuring this gap using a disposable wooden tongue depressor marked with centimeters using a ballpoint pen. Which sounds absurd at first, but I guess you don't want to be shoving a cold metallic specialized caliper. You have a teeth location whose jaw muscles are severely spasming in pain.
Exactly. It's sterile, it's disposable, non-threatening, and highly accurate. The protocol also dictates using a 2-tongue depressor technique for the exam itself.
2 of them.
Yeah. One stick pushes the tongue down and away, and the other pulls the cheek outward, because the oral cavity is essentially a wet, dark, collapsed cave.
A lovely image.
Right. A light alone isn't enough. You have to physically stretch the mucosa flat to build a temporary window into the anatomy, preventing any folds of skin from hiding a lesion.
So the doctor has built their window, the jaw is measured, the nerves are tested. But what happens when checking healthy tissue shifts dramatically and that wooden stick pulls back the cheek and reveals something that shouldn't be there?
That's the turning point.
How does the doctor's mindset shift from just taking inventory to actively investigating a threat?
They transition into medical cartography. They become map makers. The physical exam protocol clearly states that if a lesion is found, the doctor must put on gloves and palpate it. They have to physically touch the abnormality.
And they're feeling for, quoting here, consistency and fixity of overlying skin. I imagine this is where they decide if the patient is going home with antibiotics or going straight to oncology.
Pretty much.
So what does fixity actually feel like under a doctor's gloves? What invisible line are they trying to cross?
When you palpate a benign cyst, it typically feels like a water balloon trapped under a blanket. It's relatively soft, and you can wiggle it around independently of the tissue underneath it. It's not attached.
Okay, that makes sense.
But a malignant carcinoma operates differently. Because it is actively invading downward and establishing its own vascular network, a process called angiogenesis, it anchors itself. So palpating a fixed lesion feels like feeling the roots of an old tree that have grown into and merged with a concrete sidewalk. The mass is rock hard, and when you try to move it, the whole cheek or the underlying bone moves with it. It's entirely tethered to the patient's anatomy.
The vocabulary the manual forces the doctor to use to describe this is incredibly specific. They must determine if it is a growth or an ulcer, and whether it's fungating or exophytic or polypoidal.
Yes, highly specific terminology.
Fungating sounds apocalyptic.
It is a very vivid objective descriptor. Fungating means the tumor has grown so rapidly that its own blood supply can't keep up with the cellular replication.
Oh man,
Yeah, so the center of the mass dies, rots, and ulcerates, literally bursting through the skin or mucosa like a fungal growth.
that is terrifying.
It is. An exophytic mass, on the other hand, is growing outward from the surface epithelium, usually projecting into the open space of the mouth like a dense coral reef.
So the doctor touches this mass, determines it is tethered like tree roots, and then they have to map its coordinates. The text says to note the anterior to posterior extent front to back, using the patient's teeth as a map scale, but it explicitly emphasizes noting if the lesion crosses the midline of the mouth.
Yes, the midline.
Why is the midline the ultimate boundary?
To understand that, you have to look at the body's plumbing. Our lymphatic system, which is the network of vessels that clears waste and transports immune cells, is essentially divided into 2 separate highway systems for the head and neck.
Okay, 2 highways.
Right. The right side of the tongue and mouth drains exclusively into lymph nodes on the right side of the neck. The left drains to the left. So the midline of the mouth is the watershed area.
So if a tumor is strictly on the right side, the cancer cells only have access to the right highway.
Yes. But the second that tumor creeps across the exact center of the tongue or the palate, it has bridged the gap. It now has direct access to the lymphatic drainage systems on both sides.
Oh wow.
And the risk of the cancer spreading bilaterally skyrockets. The complexity of the required surgery practically doubles.
Which perfectly sets up the next mandatory phase of the protocol. After mapping the mouth, the doctor must map the neck. The manual says, get behind the patient and palpate neck nodes, which standing behind the patient seems like a strange angle for an examination.
It does seem counterintuitive, but the neck is a dense cylinder packed with major blood vessels, muscles, and chains of lymph nodes. If a doctor stands in front of you, their wrists are bent at an awkward angle and they can only feel one side effectively at a time. By standing behind you, the doctor can naturally wrap their hands around the front of your neck, using the flat pads of their fingertips symmetrically. They can simultaneously roll the tissues on the right and the left, instantly comparing the 2 sides to see if a node on the right is enlarged compared to its twin on the left.
And when they find a swollen node, they don't measure all of them. The protocol says to measure only the greatest dimension of the largest lymph node. Why ignore the rest of the data?
Because in cancer staging protocols, the largest, most aggressive node is the dictator.
The dictator.
Yeah, it sets the baseline for survival rates. If a patient has a cluster of 5 malignant nodes, but the biggest one has managed to grow to 4 centimeters, that single 4 centimeter node proves the cancer's maximum capacity to thrive outside the primary tumor site. That single measurement dictates the severity of the radiation and the aggressiveness of the surgical neck dissection.
Okay, let's look at how all of these isolated data points, the verbal history, the mouth opening, the lesion mapping, the neck nodes, must ultimately be synthesized into a single, cohesive clinical portrait.
Putting it all together.
Exactly. The final section of our sources gives an example of a description of oral cavity findings. It's written like a finalized case report for an actual patient, and the shift in tone is really jarring. It's a stark contrast.
Oh, absolutely.
It starts almost like a novel with a comforting image. An old man of average build is sitting comfortably on the examination stool.
Right, but that opening actually establishes the baseline physiological state. It confirms the airway isn't acutely obstructive, he's sitting comfortably, he's not gasping for breath.
Ah, okay.
But you're right, the literary tone vanishes instantly in the next sentence, and it has to. The objective language that follows ensures that if a surgeon in another country reads this note tomorrow, they can picture the exact 3-dimensional reality without any subjective bias.
Let's break down this final portrait, because knowing what we know now, the language is incredibly heavy. First, it notes the patient has grade 1 trismus.
So his mouth opening is between 20 and 30 millimeters.
Right.
The muscles are irritated but not fully locked. The tumor is likely deep, but hasn't entirely fibrosed the jaw joint.
Then it gets to the primary finding. It says, there is an exophytic growth on the right buccal mucosa extending from anterior camarior to the second molar.
Let's map that footprint. The anterior camarior is the exact corner of your lips. Buccal mucosa is the inside of your cheek, and the second molar is all the way at the back of your jaw.
So this mass is a continuous outward growing reef covering the entire interior wall of the right cheek.
Exactly.
And it goes deeper. The note says the growth obliterates the inferior buccogingival sulcus.
The sulcus is that deep trench between your cheek and your lower gums. If that trench is obliterated, it means the tumor's grown so massive that it's completely filled the valley, bridging the gap from the cheek wall directly onto the lower jawbone.
It also extends onto the floor of the mouth and the undersurface of the tongue. But, negative we talked about. it does not cross the midline.
So it has isolated itself to the right side lymphatic highway.
Okay, so the mass is firm in consistency, ulcerated, non-tender, and measures exactly 3 centimeters in its greatest dimension. But surrounding the tumor are leukoplakic patches. We know the patient smoked 20 cigarettes a day for 20 years. What exactly is a leukoplakic patch?
Leukoplakia translates to white patch. When mucosal tissue is bombarded by the chemical burn of smoking for decades, the cells try to protect themselves by overproducing keratin.
Oh, like hair and nails.
Exactly, the same tough protein that makes up your fingernails. The inside of the mouth shouldn't be keratinized, so these white patches are areas of hyperkeratosis. They are precancerous changes.
So it's a warning sign.
A huge one. It tells the doctor that even if they cut out the 3-centimeter tumor, the surrounding tissue is already heavily mutated and is primed to form a new cancer.
And finally, the neck nodes. The report states there are multiple firm neck nodes at level I and 2 on the right side. The largest measures 4 centimeters, and the overlying skin is not fixed. What does level I and 2 mean in this context?
The neck's lymphatic system is divided into zones. Level I nodes are located right up under the jawbone, the submandibular area. Level 2 nodes are located at the upper third of the jugular vein.
Okay.
These are the primary drainage basins for the oral cavity. So the fact that the cancer has reached these nodes confirms metastasis.
So you take the 20 years of smoking, the referred ear pain from the trigeminal nerve, the spasming jaw muscles causing trismus, the massive 3-centimeter tethered growth bridging the cheek to the jaw, the mutated white patches, and a 4-centimeter metastatic tumor sitting on the jugular vein. The doctor extracted all of that data without drawing a single drop of blood or ordering a scan.
Not a single one.
They used a patient's story, their own fingertips, and a wooden stick marked with a ballpoint pen.
Yeah, they constructed a flawless high-resolution diagnostic map entirely through the disciplined application of human observation. It is an incredible testament to the foundational mechanics of medicine.
It really is. And for you listening, I think this completely shatters the illusion of the routine checkup. The next time you go to the doctor, sit on that paper gown, say, and feel a wooden stick pressed down on your tongue. Well, you'll know. You'll know that the doctor isn't just taking a quick look around. They are running a silent, high-speed calculation of tissue mechanics, symmetry, cranial nerve integrity, and lymphatic watersheds.
It's an invisible masterclass happening right now. And it does leave me with one final question to consider, for the listener to mull over.
Yeah.
We are moving incredibly fast toward a reality where artificial intelligence and advanced digital imaging become capable of scanning our bodies instantly. They might be able to highlight cellular anomalies before a doctor even walks into the room. But if we reach a point where technology handles the discovery, what happens to the art of the physical exam? If we stop training doctors to use marked wooden sticks, their hands, and their own sharp observations to feel for the tethered roots of a lesion, do we risk losing a fundamental, irreplaceable human connection in medicine?
That is a deep dive for another day. Thanks for joining us.